Alright, so the next one is pharyngitis. So these patients will come in with very short duration of symptoms. They're usually young people and they have sore throat, difficult or not difficulty, pain with swallowing, and they usually have fever. So when you have all constellation of symptoms present and you can see there's very specific symptom, then you can say, all right, well, this could be pharyngitis. And the question then becomes, what kind of pharyngitis? Because most pharyngitis are going to be viral. So how do we differentiate between viral and bacterial? Well, we'll talk about that in a second here. Now, also in some populations, people can get chlamydia pharyngitis and herpetic or herpes pharyngitis too. And tonsillitis is a different pathology, of course, than pharyngitis, but this can also present with similar symptoms. And then on top of that, if a patient has these red flag symptoms or emergent symptoms, then we must definitely think about red pill diagnosis. So if a patient is drooling, has dysphagia or difficulty with eating, pain in one side of the neck, or they don't want to lay down, they have a tripod posture, any of these findings present, so it doesn't have to be all of them, any of these present, then we must definitely think about red pill diagnosis. And you know what those are. So those are retropharyngeal abscess, epiglottitis, diphtheria, peritonsillar abscess, infectious mononucleosis, and Lemierre syndrome. Now, as far as differentiating between viruses and bacteria, if there is cough present, then it is probably a virus. If people are not coughing, then it is more likely to a bacterial infection. On top of that, submandibular lymphadenopathy is going to be more common in bacterial infection, and people have exudate in the pharynx when you examine them in bacterial infection. So just keep those features in mind, especially the absence of cough is the presence of bacteria. So what are some of the signs or physical exam findings? Of course, like I said, pharyngeal erythema, lymph node enlargement, usually bacterial, and then with red flag diagnosis, you can see some alarming symptoms. So the signs, so these are alarming signs. You can see patients usually are tachycardiac, tachypneic, so parents say that the child has been breathing very fast. They have stridor. If upper respiratory airways involved, they can have intercostal retractions because now they are struggling to breathe, and they can have tripod posture. So we must think about all these infections, and specifically what are the signs or physical exam findings on these. Well, with epiglottitis, you can see epiglottic swelling or sunrise sign on physical exam. Now these two are very difficult to elicit because it's very hard to look at the epiglottis, but then you can also have a thumb sign on x-ray. Now this is something we must not wait for to see before we make the diagnosis. This is just a late finding, so just in case if you get an x-ray, you will probably see a thumb sign. Hopefully you've already made the diagnosis. Now in retropharyngeal abscess and peritonsillar abscess, of course you'll see the abscess, and then in infectious mononucleosis you see hugely enlarged bilateral tonsil. So this is something where the diagnosis may not be as life-threatening, but if the tonsils become too big, then it can become a problem. In patients with Lemierre syndrome, usually have unilateral neck tenderness, and again, this will be a patient who will not be your walking, talking patient, but this patient is already probably hospitalized, and they're already sick and septic, and now on top of that, the guy has developed Lemierre syndrome. How do we treat them? So again, based upon the bacteria that cause all these infections, we can do penicillin, cephalosporins, and azithromycin. So you can see these three big broad coverage antibiotics are going to cover most of the head and neck infections. So here is a slide to show thumb sign. So you've already seen this x-ray before. This is a hallmark of epiglottitis, and then this is a direct visualization of peritonsillar abscess. You can see pretty big tonsil here, and then this is just to show that these lymph nodes can be involved when we are thinking about pharyngitis. All right, so let's look at the next disease which involves the bronchioles or the small airways, and this generally speaking will affect only children. So this is a pediatric problem. That's because they have small airways, so that's how it spares the adults. Now, how do these patients present? Usually they are very young, younger than 2 years of age. Symptoms usually last a few days before they come in, so sometimes within a day or two, but almost never more than 1 week. And they have these symptoms, and you can see there are lots of different symptoms: fever, shortness of breath, and tachypnea. They don't really say that they have shortness of breath, but because they're breathing so fast that parents notice it. They can also have cough and wheezing and crackles on exam. So these are basically very these are the findings that can be present in some other infections or diseases as well. So for example, a patient with pneumonia, a young patient, can also have pretty much all of these symptoms and signs. So how do we differentiate? Well, one thing, bronchiolitis patients usually have low-grade fever, not high-grade, because it's a virus infection. The other thing is with pneumonia, especially if it's a lobar pneumonia, there will be signs of consolidation on one side. So that's how you can tell. The other thing is that patients with bronchiolitis have usually, like I said earlier, more constellation of symptoms. They just look very, very wiped out. They have a face that looks like, when you see them, you can remember how they look. And they also have a lot of congestion, runny nose, matty eyes. Another thing to remember is that a lot of patients who get bronchiolitis, it's because of RSV, or respiratory syncytial virus, and that virus is much more common in premature babies. So if your baby is premature, and let's say a 6 months old baby, and they're coming in with these symptoms, then definitely check for RSV. On top of that, there are viruses like rhinovirus and flu and adeno and coronaviruses that can cause bronchiolitis too, but not nearly as bad. RSV is the biggest ugly virus that causes all these symptoms. Treatment, unfortunately, we don't have any antibiotics, of course, because it's a virus infection, so it's going to be largely supportive. A lot of these babies will need some oxygen, so they will need to be hospitalized for that reason, and they need to be monitored. We need to give them a lot of fluids, because that's what's going to keep them hydrated and back to recovery. And then the prevention is available, so we have RSV vaccine that we give to premature babies, and there is a specific protocol for it. So that's good news. Here is an X-ray showing RSV bronchiolitis. So you can see that one of the 3 different findings you can see on the X-ray. So people can have patchy atelectasis. You can see right here in the middle lobe, and then they can also have bilateral bronchial infiltrations. They can also have some flattening of the diaphragm. So that is usually because they are trying to expand their lungs, and that's how you see flattening of the diaphragm. Alright, so the next is pneumonia. So for the purpose of this talk, this pneumonia is just pneumonia in adult patients. So I'm not talking about children. We already discussed a few differentiating features between pneumonia and bronchiolitis in children, but this is just for adults. So what are the symptoms? People come in with fever, productive cough, and green phlegm and shortness of breath. So these are the prototypical symptoms. So not all patients have all these symptoms. They may just have shortness of breath and fever. They may just have productive cough and fever and things like that. But anyhow, they are going to be usually your very young, very old, or adult patients, and they have these symptoms for quite a few days now. So remember, pneumonia can also be because of viruses or bacteria, but usually bacteria will cause more fever and productive green phlegm. So what are some of the signs on exam? You'll see tachypnea, tachycardia. They can get hypoxia. If this is the case, then it is a red flag situation. So always look at the oxygen saturation level. And then also, if this is the case, then now they need more intense treatment, and maybe even hospitalization. So on lung exam, you can see hear some rhonchi or crackles, and then if it is a lobar pneumonia, which is usually consolidation on one side, then you'll see that there is dullness to percussion and all the findings of consolidation. What is the test that we need to do for pneumonia if we're suspecting it? Well, we do a chest x-ray and a CBC. So CBC will just tell us that, okay, well, there is some systemic infection now, so infection is spreading, and it also is good for monitoring purposes, so to monitor the treatment. But chest x-ray is important too, to see the extent of the disease, and also make sure that there are no complications with pneumonia. For example, if somebody, let's say an elderly patient comes in with pneumonia, and you make your clinical diagnosis and you start treating them, but they're not getting better. If you've already done the chest x-ray, you'll see that maybe now they've developed parapneumonic effusion. So you may then in that case need to tap that effusion or give stronger antibiotics. So that's how chest x-ray is helpful. Etiology, again, you can see the biggest bacteria. The most common is strep pneumo. Then you have Moraxella, that usually causes walking pneumonia. Then you have staph and Legionella, and then less common are fungal pneumonias. And then of course flu, which is a virus, can also cause pneumonia. Treatment will basically largely depend upon these bacteria, and we already now have seen that penicillin and cephalosporins will cover most of these bacteria. If it's Moraxella, then azithromycin will be good. If it's virus infection like flu, then it's Tamiflu. And then in some situations, for example, for bad staph infections, vancomycin will be given, and then all the nursing home patients should be given vancomycin. Another thing to remember is that the clinical picture for staph pneumonia, that is one special kind of pneumonia, will be slightly different. These patients a lot of the times have preceding viral illness, so they have viral symptoms for quite a few days, and then they come in with high-grade fevers, and now you know that they have developed pneumonia because of staph infection. And then the special category would be if you've done the treatment and the patient's been treated for quite a few days and they're not getting better, then we must start thinking about complications. For example, either pleural effusions, or another thing would be lung abscess. So patients with lung abscess will continue to spike high-grade fevers despite treatment. And what is the population that's going to be at risk for this? It will be basically your alcoholics and patients who are at risk for aspiration. For example, your patients with stroke who can't handle their secretions, or even patients after a seizure can aspirate their contents. So that's how they can develop lung abscess. And of course, when you are suspecting it, or after chest x-ray you've diagnosed it, then you either need to give broader coverage in the form of anaerobe coverage as well, like clindamycin, or in some cases you may need to drain it. This is a chest x-ray showing pneumonia, so you can see there is a lobar consolidation, and then there is another x-ray showing a lung abscess, so on the right side. Alright, so the next is infective endocarditis, which is a very interesting phenomenon. Now this is luckily a disease. It doesn't happen to every walking, talking regular person. There are special populations that are at higher risk for infective endocarditis, so that makes our job easier, because patients with infective endocarditis don't usually present with typical symptoms or focal symptoms. So they do have a lot of fever and chills, and usually the fever is high grade, but they don't necessarily have chest pain or shortness of breath. So this may or may not be present. Most of the time it is fever and chills. And there is a criteria called Duke's criteria to make the diagnosis for infective endocarditis, but I'm not going to go into detail on that. What is the patient population that is going to be at risk? So if you have these risk factors present, then we must think about infective endocarditis. So that's how you can see that history becomes very important. If you have a patient who comes in just with high-grade fever and chills, and you don't really see too many other focal symptoms and signs, maybe some shortness of breath, generalized dullness or dull pain or something like that, and you start looking for risk factors. If they do have these present, then definitely look for an infective endocarditis. So the risk factors are IV drug users, that is the biggest risk factor. Then patients who have prosthetic devices, for example, a patient who's already hospitalized and has a catheter or a foreign body of any sort. And it doesn't have to be a fancy foreign body. It can be as simple as a PICC line, which is the peripheral intravenous catheter. They are at risk for developing infective endocarditis. Patients who have structural heart disease, for example, a bicuspid valve or something, they can also develop infective endocarditis. Now, what are the signs when you're suspecting it? Then these are the signs we should start looking for. So they may, most of the time they're going to be very tachycardiac, so they have an S3 gallop because of failure if they start to develop that, and if they're not treated very quickly, then they go into heart failure very fast. Also, they have a murmur of the valve that is involved. So for example, the most commonly involved valve is mitral valve, except in the case of IV drug users, they can get their tricuspid valve involved also. So you just have to keep that in mind. If you see tricuspid valve as the focus for infection, then it's probably IV drug use, because they affect, for whatever reason, the right-sided valves more commonly. These are the very specific signs on physical exam, and almost never you will see all of these signs together, but if you do see them, then of course that's a good thing, because now you can easily make the diagnosis. So these are rod spots that are retinal hemorrhages in the eye, then ocular nodes on the fingers, on the palmar side, and there are small nodules, and then there are Janeway lesions, which is basically palmar erythema, and then there is splinter hemorrhages in the nail. So you can see there is a lot of extremity or distal extremity signs, and that is because there is a lot of microemboli going on. What are the complications? Like I said, congestive heart failure is the biggest complication. It happens very fast, so that is why it becomes extremely important to treat and recognize infective endocarditis very quickly. And the other complications would be patients can go into hypotension and then shock, and then a lot of the times they can develop emboli, so a clot starts to form in the heart because of the turbulent blood flow. And then of course, where does the clot go? Blood clot go from the heart, it will go straight to the brain, not to the lungs, so they can get stroke. These are the slides showing all those physical exam findings that I just talked about. So these are rod spots, so keep this in mind. These are retinal hemorrhages, Janeway lesions on the palms, then there are ocular nodes, you can see some nodes on the fingers, and then there are splinter hemorrhages. So all these four, if present, of course, then definitely make the diagnosis of infective endocarditis, but you don't really see them all together, so just keep that in mind. You may just see one or two. So regardless, you will make the diagnosis based upon Duke's criteria and anybody who has risk factors and has high-grade fever. So this is an echo showing the mitral valve, which is most commonly involved, and occasionally you can see aortic valve involved as well. So in the case of mitral valve, the murmur would be in the mitral area, and it will be pansystolic murmur. Etiology, so this is important to keep in mind too. Staph aureus is the biggest bacteria, or the most common bacteria that causes infective endocarditis. This is very common in IV drug users, so that's how they get it. If a patient has a history of colon cancer, for whatever odd reason, they are at risk for getting strep bovis, or streptococcus bovis infection. Patients who have abnormal valves or structural valves, they can get streptococcus viridans. Patients who have a prosthetic valve, so basically a foreign body or prosthetic valves, they can get strep epidermidis. So you can see strep is a common theme here, except that staph is the most common bacteria that causes infective endocarditis, just in general population as well as in IV drug users. And then lastly, you have enterococcal bacteria, and then you have Hayseck organisms, which are gram-negative rods. 10% of infective endocarditis patients have Hayseck infections. And then occasionally you will see immunocompromised patients who get fungal infection as well. So these patients are going to develop a slow indolent course and don't come in with a dramatic picture. Treatment would be, of course, if there is a foreign body or prosthetic device, you got to remove it. If you have any complications, for example failure, you will treat that. Parenteral antibiotics will be required. Oral antibiotics are not going to cut it. So vancomycin is the drug of choice because it covers pretty much all of these. Long duration of treatment, like at least 6 weeks, is required for it. And then if your medical treatment is not working, then surgery is the answer. The sister diagnosis to infective endocarditis is myocarditis, but it presents quite differently, because myocarditis is basically because of a virus infection. So these patients will come in with much more insidious onset of symptoms, so they are not as dramatic. A fever is low grade, and they come in with chest pain. Usually chest pain is because now they've developed pericardial infection as well as myocardial infection. So it's usually myopericarditis, and then also have, of course, shortness of breath because now they've got some cardiac dysfunction going on. Risk factors, so there will be some risk factors for myocarditis as well, not as striking as for endocarditis, but these patients can have a preceding viral illness. So they usually can tell you, if you ask them, that they they were sick with a virus for a few days and now they are even more sick. And on exam, you can see some S3 gallop most of the time, which is basically showing that there is some failure going on. And when you do their test, so EKG will show some non-specific STT wave changes. They may show some arrhythmias because of conduction abnormalities. Chest X-ray will show some dilated cardiac shadow if it has progressed to that point, and usually it does. And then troponins may be elevated. So remember, the troponins are going to be misleading in some ways because they are going to be high, but it is not really the coronary artery ischemia. So just keep that in mind. So a patient will have chest pain as well. So these two can be distracting, but this chest pain is not going to be typical cardiac chest pain. They do have low-grade fever as well. This chest pain is very generalized all over the chest. It's not exertional, it's not radiating, so those sort of things. Now you can also draw Bnp levels, which is brain natriuretic peptide levels. These will be high, showing failure. Then echocardiogram will show wall motion abnormality because of the myocardial involvement, and that's how you can make the diagnosis. The final diagnosis, or the gold standard diagnosis, really is the biopsy. You can also do MRI, but biopsy will really tell you that there is myocarditis. Complications will be heart failure, pericarditis, and dilated cardiomyopathy. So again, these people can go into hypertensive shock, and then it becomes very difficult to treat them. So etiology, again, in addition to these viruses, there can be influenza and herpes virus as well. And of course, treatment is for the complications.